Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Do you recognize this patient? You've probably seen his image somewhere. Burkitt lymphoma, ring a bell? I'm going to be talking about this and much more in today's talk, which is on lymphoma pathology. Make sure you have your book. This topic is very important. It's tested very frequently. So bust out your highlighter, your pens, take notes, do what you need to do to make sure that this all sinks in. Lymphadenopathy. Large lymph nodes. Large lymph nodes are referred to as lymphadenopathy. They can be palpated on physical examination, and they can even be visualized by ultrasonography and other imaging modality. Typically, lymph nodes that are draining in areas of acute infection show painful lymphadenopathy. Here we have a computed tomography image of retroperitoneal lymphadenopathies of testicular seminoma around the aorta. You see that? You should consider radiology. Causes of lymphadenopathy include benign lymph node hyperplasia, reactive lymph nodes, acute inflammation, metastatic cancer, chronic inflammation, and lymphoma. Hyperplasia of specific lymph node areas causes lymph node hypertrophy during inflammation. For instance, early phases of infection and rheumatoid arthritis both exhibit follicular hyperplasia in the B cell area of lymph nodes. With viral infections, pericortical hyperplasia in the T cell areas is observed, such as the case of infectious mononucleosis. Now, we've already talked about this, so I'm going to ask you a question. What do the activated T lymphocytes look like on the peripheral blood smear for infectious mononucleosis? You remember that? How they have that sort of bluish hue as they embrace the neighboring red blood cells? You remember. And if you had a patient with mono, what would you tell them not to do? Right, you tell them not to partake in physical activities such as ice hockey, football, MMA, right? We want to avoid them hemorrhaging with a ruptured spleen, right? It's very important. In regards to lymphadenopathy, in lymph nodes that drain cancerous tissue, sinus histiocyte hyperplasia might be observed. Lymphomas are the malignant proliferation of hematopoietic cells involving a lymph node or extranodal tissue, such as MALT in the gut or the spleen. Lymphomas are generally characterized as either Hodgkin lymphoma or non-Hodgkin lymphoma. Non-Hodgkin lymphoma is further divided into subtypes based on the expression of surface markers, cell size, patterns of cell proliferation, cell type, and even cytogenetic translocations. Non-Hodgkin lymphomas are broadly characterized into two groups, or categorized, I should say, into two groups: natural killer or T cell lymphomas or B cell lymphomas. Natural killer or T cell lymphomas account for approximately 15% of non-Hodgkin lymphomas. B cell lymphomas account for the majority, coming in at 85% of non-Hodgkin lymphomas. Non-Hodgkin B-cell lymphomas include, for your purposes, acute lymphoblastic lymphoma, follicular lymphoma with those back-to-back follicles, mantle cell lymphoma, marginal zone lymphoma, diffuse large B-cell lymphoma with its gritty abnormal cells and cellular debris and high Ki, Burkitt's lymphoma with that starry sky background and also a high Ki, and chronic lymphocytic leukemia / small lymphocytic lymphoma, which we've touched on already. Okay. In regards to lymphoma, we're going to be discussing some of the more commonly tested entities, okay? I'm going to make sure you know everything that you need to know. And if you have any comments, questions, or concerns, let me know. Make sure you're subscribed. And if you want the real deal, high yield, make sure you have access to the website. In this image, we can see all sorts of vacuolizations. This is showing Burkitt lymphoma on what we call a touch prep. It's a special procedure where the tissue that's been obtained from the surgery that's probably going on right before this sample was prepared in the pathology room. With regards to lymphoma, a lot of radiologists can pick this up with their various imaging. For example, we have a CT scan here with this yellow arrow pointing at an enlarged, abnormally shaped axillary lymph node in a 57-year-old patient with multiple myeloma. Now, mantle cell lymphoma can affect various tissues. Commonly, the GI tract is affected. So here we have a micrograph of the terminal ileum involved by mantle cell lymphoma. With regards to extranodal sites involved in non-Hodgkin lymphoma, Walderius rings, including the tonsils, palate, and nasopharynx, and the base of the tongue can be involved, as well as the GI tract, stomach, and the small intestine and colon, the nose and sinuses, various areas, even the CNS can be involved. Here we have histology of a patient with retinal lymphoma. The patient presented with decreased vision in the right eye. And we can see here in the image diffuse basophilic cells. This is retinal lymphoma, large B-cell type. Take a look here. This is splenic marginal zone lymphoma. Now, the morphology of splenic marginal zone lymphoma is characterized by a nodular pattern where the splenic marginal zone lymphoma is centered around white pulp with various variable red pulp infiltration. Can you tell me what this image is here? If you're thinking fish, you're thinking correctly, right? Because fluorescence in situ hybridization, a cytogenetic technique, can actually be used to visualize karyotype abnormalities, such as translocations or losses or deletions or duplications of CCND1, which is cyclin D1, which is present in mantle cell lymphoma. Note that the positive pattern showing the two separate red and green signals is present in mantle cell lymphoma. Now here we're seeing diffuse sheets of cells that are large with various morphology. This is diffuse large B-cell lymphoma. Note that there are prognostic factors associated with diffuse large B-cell lymphoma, which include p53 and BCL2. Also keep in mind that diffuse large B-cell lymphoma has a high Ki67 proliferation index. Now here's an image of mantle cell lymphoma involving the terminal ileum. Mantle cell lymphoma consists of small B cells, which are CD20 positive, and it is a neoplastic growth that increases the mantle zone. Also, keep in mind that mantle cell lymphoma can be stained with cyclin D1 immunostain. Mantle cell lymphoma clinically presents with lymphadenopathy that is painless, and it's usually present in adults. Mantle cell lymphoma is typically driven by a translocation between 11 and 14. You remember that, you know all the translocations of importance. Now on chromosome 11, the cyclin D gene moves to the Ig heavy chain locus. Cyclin D1 overexpression encourages the transition of the cell cycle from G1 to S, aiding the growth of cancerous cells. Now here we have a lymph node with diffuse basophilic sheets of small cells, which is classically seen in mantle cell lymphoma. Again, GI tract involvement by mantle cell lymphoma. Note that the immunohistochemical staining for mantle cell lymphoma will be positive for cyclin D1, right, because that translocation is impacted, as well as CD5, CD43, CD23, and CD45. And it's usually negative for CD23. You recognize this? Yeah, fish for cyclin D1, right? I'm reiterating this to make sure that you know what's mutated with mantle cell lymphoma. And you know. Regarding mantle cell lymphoma, let's take a look at these panels. In A, we have an H&E stain where the germinal center is surrounded by thick lymphocyte sleeve. In B, we have cyclin D1 positivity in those cells that are surrounding it, but it's variably low, right? And in C, we can visualize the germinal center with this stain, Ki67, right? Because within the germinal center, in general, in normal lymph nodes, there's a higher proliferation index. With regards to marginal zone lymphoma, it usually consists of small neoplastic B cells that are CD20 positive, that are proliferating, which expands the marginal zone. Marginal zone lymphoma is associated with long-term inflammatory conditions such as Helicobacter pylori gastritis. Oh, that makes sense. That's why it happens so much in the GI tract, in the terminal ileum, right? In the small intestine, right? Because that H. pylori gastritis, right? Even other regions within the gastrointestinal tract. Marginal zone lymphoma is also associated with some autoimmune conditions, such as Sjogren's syndrome and Hashimoto thyroiditis. The B cells of marginal zone lymphoma from the post-germinal center form the marginal zone. Mucosal associated lymphoid tissue, or MALT lymphoma, is a mucosal site marginal zone lymphoma. Treatment for H. pylori may cause the gastric MALT lymphoma to actually regress. Here we have an image of an extranodal marginal zone lymphoma. You can pause it and read it in detail, but we've definitely went over all the key points that you need to know. So if you're feeling extra detailed right now, you can pause and read this. But for brevity's sake, we're going to move on. Right? Now this is important. Note that splenic bleeding can occur in marginal zone lymphoma, and that could be picked up with the CT. Marginal zone lymphoma impacting the spleen is typically termed splenic marginal zone B cell lymphoma, and it can have various patterns, but note that it's usually positive for CD20. Now let's talk about Burkitt lymphoma. This is commonly tested. Burkitt lymphoma is due to the neoplastic proliferation of intermediate-sized CD20 positive cells. Right? You see these vacuolizations? You remember this patient? Note and keep in mind that Burkitt lymphoma is associated with Epstein-Barr virus. Some common clinical features of Burkitt lymphoma include usually involving children or young adults, typically presenting as an extranodal mass, commonly affects individuals of African descent. The jaw is typically involved, as well as the abdomen. Note that Burkitt lymphoma is driven by c-Myc translocations on chromosome 8. The most frequent mutation in Burkitt lymphoma, you must know this, I know you know it, translocation 814, right? 814 for Burkitt lymphoma. Translocation 814 causes c-Myc to be translocated to the Ig heavy chain gene on chromosome 14. c-Myc oncogene overexpression encourages cell proliferation. And guess what? That's why in Burkitt's lymphoma, that cell proliferation, it's just going. That's why Ki-67 is so high. It has a high proliferation index. It's so high that you can even see it on H&E. And that's why we give it that quote-unquote starry sky appearance. Burkitt lymphoma classically has a high mitotic count and a starry sky histologic appearance due to the abundant tingible body macrophages, okay? For all my classical art enthusiasts out there, take time to reflect on this image. Pair it with Burkitt lymphoma. You're smart. Burkitt lymphoma. It's definitely going to show up. Buzzwords, starry sky pattern. It will have a high Ki-67. It's associated with EBV in the endemic cases, not the sporadic ones. Here's another example of Burkitt lymphoma in a child. Look at this large mass affecting the jaw, okay? Burkitt lymphoma, takeaway from this image is that it's EBER positive. EBER is a type of specific immunohistochemical stain that pathologists use to stain for EBV, okay? So EBER positivity helps confirm that this is Burkitt lymphoma, at least the endemic type. And here is another example of Burkitt lymphoma, this time expressing LMP1 in EBV infected cells. And again, Burkitt's lymphoma. Note that high Ki-67 in the bottom right, panel F. And you can see that again here. Do you see all these cells with the high mitotic rates? Do you appreciate the large pale macrophages, quote unquote, the stars in this image? Burkitt's lymphoma. It will show up. Let's move on to diffuse large B-cell lymphoma. In DLBCL, you have typically CD20 positive cells that are neoplastic. and proliferate and spread out in sheets. They have this somewhat gritty, debris type background picture, right? These cells are ugly. Diffuse large B-cell lymphoma is the most common type of non-Hodgkin lymphoma. Diffuse large B-cell lymphoma may be due to spontaneous mutations or result from a low-grade lymphoma transforming into DLBCL, such as follicular lymphoma transforming into DLBCL. DLBCL typically presents as an extranodal tumor or an expanding lymph node in late adulthood. Takeaways from this image is that DLBCL stands for various things and it looks ugly. If you see a lymphoma with a lot of background debris, think diffuse large B-cell lymphoma. That's a takeaway. And note from this fish here in J and K that certain mutations involving BCL6 and MYC are implicated in diffuse large B-cell lymphoma. Finally, we're going to talk about Hodgkin lymphoma. Hodgkin lymphoma is characterized by these cells that I know that you've seen them before. Reed-Sternberg cells. You see that? You see those owl eyes? Hodgkin lymphoma is characterized by Reed-Sternberg cells. Reed-Sternberg cells are giant B cells with multi-lobed nuclei and noticeable nucleoli, hence the buzzword owl-eyed nuclei. The Reed-Sternberg cells release cytokines, okay? Cytokines are released by these large Reed-Sternberg cells, which actually recruit lymphocytes and plasma cells and macrophages and eosinophils to the area that surround the large Reed-Sternberg cells. Now, the majority of the tumor is made up of normal inflammatory cells, right? So you got to be careful. You got to look closely. You got to find the Hodgkin cells. You got to find the Reed-Sternberg cells. You got to be looking for what's looking at you. What's looking at you? Owl eyes. You have to find them because those are the neoplastic cells in Hodgkin lymphoma. Now, there are various subtypes of Hodgkin lymphoma. Ones that you need to know include classic Hodgkin lymphoma. This is the normal expected immune cells that surround the Reed-Sternberg cells. There's also nodular sclerosing Hodgkin lymphoma, which actually, according to the WHO, is going to be recategorized in the near future. And by near future, that's probably 3 or 4 years. So for examination purposes, remember nodular sclerosing. And that one specifically has bands of fibrosis that cross lymphoid tissues. Another type of Hodgkin lymphoma is the lymphocyte-rich Hodgkin lymphoma. And guess what? It's lymphocyte-rich, which means it has lots of lymphocytes. Ooh, lots of lymphocytes. That's good. Best prognosis. On the other hand, you have the subtype of Hodgkin lymphoma that is lymphocyte depleted. I don't like that because it has a worse prognosis. Yikes. Symptoms of Hodgkin lymphoma classically include the B symptoms. What are the B symptoms? Well, the B symptoms are fever, chills, and night sweats. So your patient might be complaining of feeling hot and cold and their sheets being wet, waking up in the middle of the night feeling like they're soaked. B symptoms. Young adults, typically females, are those that get Hodgkin lymphoma the most. Patients with Hodgkin lymphoma typically present with enlarged cervical or mediastinal lymph nodes, as well as B symptoms. Hodgkin lymphoma is positive for CD15, CD30, PAX5, MUM1, and FASN. Now let me point out that we know that the hyperplasia that's taking place in Hodgkin lymphoma is specifically those large cells. So with immunohistochemistry, be careful, because you have a bunch of normal inflammatory infiltrate, normal eosinophils, normal lymphocytes that are around. The neoplastic cells are the large Hodgkin cells. Those are the ones that are CD30 positive. Those Hodgkin cells are the ones that are CD15 positive cells. Those Hodgkin cells are the ones that are PAX5 positive, MUM1 positive, and FASN positive. Okay? You got it? Good. Hodgkin lymphoma, again, those large cells, are negative for CD20 and negative for CD45. And with that, you wrapped up a super high yield lecture. I'm proud of you. I'm so proud of you. You don't even know. Great job. Excellent, 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 excellent. Wow, you're so smart. Keep studying. You're going to do great. And I'll see you next time. Keep up the good work.